everyone, and welcome to this policy dialogue session. I see there's quite a few people online already, so let's get going. Thank you so much for joining us. My name's Ave Ribbons, and I'm the coordinator of the policy dialogues. So I don't know which continent you're coming from, but good morning, afternoon, or evening to all of you. Policy Dialogues is the name of a series of transdisciplinary seminars from the Johns Hopkins University Universitat Pompeu Fabra Public Policy Centre, and they aim to make knowledge around policy making and its impacts on people's quality of life, well-being and equity more accessible. So today we're celebrating the 24th Policy Dialogue session, and it will also be the last session of 2025. So thank you all for joining us for this last session of the year. You can see the whole videos of all of the previous sessions on the Centre's YouTube channel, which I'll share in the chat later. So today we have the privilege of inviting 3 experts from different countries to discuss the climate crisis and its impact on public health, and to explore how health policy needs to adapt to the current context of unprecedented temperatures, extreme weather events, and rapid changes to the climate and ecosystems. This is an extremely urgent issue, as we all know, as each year we're seeing more and more records being broken in terms of extreme weather and extreme heat. And more people's health, livelihoods, and lives are being affected by this. So I'm really delighted to introduce the 3 speakers for today. Firstly will be Enrique Castro-Sánchez, who has positions as an advanced IPC clinical nurse specialist at the National IPC team in the UK Health Security Agency in London, an honorary lecturer in infection at Imperial College London, and an adjunct professor in planetary health at UOC in Barcelona, Spain. He's also a visiting professor in global health at the University of the Balearic Islands in Spain. And Enrique's research focuses on how people make decisions and use antibiotics and the factors and structures which influence such decisions. Thanks for joining us today. Secondly, Sonia Angell will present. Sonia is a physician and expert in public health, policy and systems change, with over 15 years experience in government from the local to the global level. She's a Bloomberg Distinguished Professor of the Practice at Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology, with a joint appointment in Environmental Health and Engineering. She's also an Assistant Clinical Professor at Columbia University's Vagelos College of Physicians and Surgeons. Dr. Angell's research aims to increase public health and healthcare delivery system capacity to protect human health from the impacts of climate change. And finally, Laila Vivas. Laila is a researcher and activist specialized in political ecology and ecofeminism, focusing on the intersections between environmental justice, health, and climate. She holds a PhD in social communication from the University of the Basque Country in Spain and the Basque Center for Climate Change, or BC3, where her research explores transdisciplinary approaches to environmental and health injustice and conflict. Her work also combines academic research with creative and transdisciplinary methods to explore how social and cultural imaginaries shape perceptions of health, climate, and sustainability. So I'm really delighted to invite the 3 of them to present with us today and present their research. They're each going to do a presentation for around 20 minutes or so, and then we'll have time for some questions and answers. So I encourage you to all write your questions and comments in the chat below, and I'll be reading them out at the end of the session. So without further ado, I'll pass it over to Enrique. Thank you so much.
Okay, thank you so much for the opportunity to be here with you all today. I hope that you can hear me okay. As you can probably hear, I'm enjoying the winter season for infections. But here today, I just wanted to give you a bit of context about the challenges that national public health agencies have to deal with in terms of the climate crisis and the response to the climate crisis in the current social political context. Obviously, the talk just represents my opinion, and doesn't necessarily or at all represent the opinion of my employers or any of my affiliated institutions, and any mistakes can only be attributed to me. Obviously, also any reflections on policy doesn't necessarily reflect the position of the UK Health Security Agency, the National Public Health Agency in the UK, and here's my declaration of interest. I suppose, but I always like to check, I suppose that you're here because you do believe that temperatures are increasing and that they are increasing as a result of human activity. There may be some background increase in temperature for other reasons, but I believe that you're here because of that certainty that we humans, our species, is responsible for that increase in temperature. An increase in temperature that, as we've seen in the recent COP, has surpassed the previously assumed safe limits of increase, and we're now reaching other limits which are certainly unsustainable for human life and the life of the other beings in the planet. But I think it's always important to, set the rules of the game very clearly at the beginning and make sure that everybody agrees with those. And you can see on the bottom right the beliefs of many of the scientists who took part in the IPCC report about where we're going. So this is the context, this is the macro, this is the planetary context, and this is the reason why we are certainly concerned about the challenges and the impact that this increase in temperature is having. There is no country, there is no nation, there is no global citizen able to escape from the consequences of this climate crisis. And we are already seeing, and we have seen for some while, how patterns of disease, of mortality, of infrastructure damage and stability have been shaped by the increased temperature, the lack of the loss of biodiversity, and essentially the warmer, wetter, and weirder patterns that we're seeing. And you got here 3 examples, particularly the one in the middle referring to Pakistan, a country that I hold very dearly in my heart for many reasons, the impact on these global citizenships. Coming from a public health agency and focused on human health, data from the World Health Organization reflects data from many national agencies where, we are seeing an impact on health, but also we are projecting additional deaths in the region of 500,000 between 2030 to 2050 from several reasons related to the climate crisis or consequence of climate crisis. So that's sort of like a mega macro context. But obviously, what we find particularly interesting about the climate change or climate crisis is that it's not a single risk. It has got the ability of enhance and multiply pre-existing risks and inequalities. So you have got here, again, some of the increasing evidence of the impact of the climate change on some of the infectious-related risks, environmental-related risks, and particularly these peaks of heat and extremes and the impact that it has had over the last close to a couple of generations. So from a public health agency, already this presents a challenge as the syndemic of climate crisis and other endemic harms is not something that we're very well equipped or very used to deal with. We're very good at dealing with fairly discrete, single isolated risks. But when it comes to this combination and multiplication of risk, we have got some challenges, not just in the UK, but around the world. And obviously, when we talk about health, when we mention health, you should really always assume about the economic toll, economic impact at the micro, at the individual level, at the systems level, and at the health systems level. Again, I don't really have to say much about the increasing dramatic, brutal economic burden borne by individuals, but also borne by any of the infrastructures, economic infrastructures. And you have got there already some of the impact already measured, 640 billion potential labor hours lost, equivalent to the GDP of Indonesia. Again, another country dramatically affected by the climate crisis or heat crisis. If you come from classic public health and you thought that you wouldn't have much opportunity to practice everything you learned about inequity, inequality, disparity, and unjust differences between populations, the climate crisis offers you an emerging, sad, beautiful opportunity to, demonstrate and develop your skills. And we are already seeing the emergence of this climate apartheid, where the high income emitters having that impact on low income sufferers or people in the lowest rungs of socioeconomic position. So it's not just that the impact is affecting the global citizenship, but of course, as we have seen in the classic public health problems, those most vulnerable are disproportionately affected by those challenges, and they are least likely, or most least likely, to be able to implement solutions and mitigations to this problem. And I always like to reflect upon how do you plan your health services and your public health portfolio in a setting such as Sao Paulo there, where you have got that stark inequality living side by side. The challenges are obvious, the challenges are important. What is also striking is that the readiness and our preparedness is truly insufficient for many reasons. Some of them perhaps legitimate in terms of having the data to plan those mitigation strategies, but truly insufficient at the global scale. Not only we are inadequately prepared, but it looks like the chronic underinvestment is likely or is due to remain for some more time, again, as we have seen in as a result of what we've seen in some of the international meetings and summits, isn't it? The one just sort of like I recently finished. So it looks like adaptation in terms of health is receiving less than 1% of overall climate finance. And that's clearly insufficient to be able to adapt and mitigate the impact of the global climate crisis. Now, that's quite a little bit of information about the context, what all these matters for public health agencies, national public health agencies, is reflected here. This context is already translating into growing caseloads, particularly related, of course, to pathologies associated with the climate crisis, but also which can be seen as a more acute impact. But also we are seeing medium-term and long-term impacts, particularly in relation to national and international infrastructures and the overlapping crisis. The age of the perma crisis is upon us. And we are, leaving one localized crisis simply to fall into the next localized crisis. Again, public health agencies, we are built to respond in a particular way, and we're not that well built to respond to this perma crisis, maybe because of the mandate that we have typically from governments. We are fairly equipped and built for acute crisis, but certainly not for the generational and intergenerational threats presented by the climate crisis. With the acute model, the vertical programs that are fairly in vogue for our public health agencies, we have got fairly well measurable outcomes, and we love protocols, and we certainly are, under the weight of discrete funding cycles, which is completely inappropriate, if you ask me, to deal with the impact of the climate crisis and the response needed for the current climate model, isn't it? We don't really have, I suppose, like any planetary problem, uncertainty is a defining feature. Synergies in the different points of the loops are something that we haven't been able to grapple yet. And again, the requirements for this system transformation is something that we cannot really influence as much as we would like. The consequences as well of this overall planetary problem, such as the climate crisis. Well, we really don't have the institutional capacity, we don't have the workforce, we don't have the finance, and we don't have the systems to be able to respond to the pace of change. Even if we have got these assets, we don't have them at the speed and the volume that the climate crisis requires. So, we also have got to deal with our institutional crisis and the policy crisis. One of the biggest crisis that we have to address as well is the governance gap at the global level. Again, like any other planetary problem or planetary issue, collaboration and altruism between not just agencies, but between nations and interests is something that we're yet to build. As we saw with the vaccine diplomacy, if you remember the response by many countries to the recent COVID pandemic, we were much more interested in hoarding vaccines, a very valuable asset, rather than thinking about the global diplomacy and the global common good, which ultimately has ended up having no great consequences for countries, particularly in the global north. We also, I suppose, subject to the challenges of the different cycles. One of the cycles is the electoral cycle, 4 or 5 years, maybe a 10-year cycle. If a particular party thinks or is able to maintain itself for 10 years, a couple of elections, and that's really the tempo of that electoral cycle is very different to the climate cycle, isn't it? So how do we juggle the two ages, the political age with the planetary age is something that probably by its very nature cannot be reconciled. And I suppose that one unexpected, emerging, certainly worrying risk that public health agencies we're having to deal with, or at least having to learn how to deal with, is of the political polarization and how increasingly we have got data about how health behaviors or the response to health-focused interventions is increasingly partisan. So people with a particular political orientation will, by definition, respond to our interventions and our messaging in a very different way to others. Scientific advice is politicized. So if you think about that, the ethos of a scientist is providing evidence-informed advice to the decision maker or the political decision maker. If expertise is now not a badge of honor, but a badge of dishonor, according to some political figures, then we have got a problem. And also the fact that many of our health impacts are secondary to other non-health pieces of legislation. And if there is any gridlock in terms of the legislation, then of course our work is severely hampered. So how do we deal with that legislative gridlock? In addition to political polarization, many public health agencies around the world are also threatened by those political views. And I'm showing you here a really recent report about how institutions such as the National Public Health Agency in the UK, together with a few other institutions, it's vulnerable in terms of if there are political changes or changes in the in government. And you can see how we depend very much on that government to secure our funding, to set priorities in terms of the leadership, appointment, and accountability. So these challenges, something that probably, if not certainly, many public health agencies around the world will also be experiencing, and how difficult it may be to provide evidence-based or evidence-informed independent advice. Is some of that advice may threaten the continuity of your funding or your leadership. So how do we marry those two challenges? Coming to the end of this really brief context setting, another movement that it's increasingly threatening our work is this organized resistance landscape. So how the concerted efforts of industry and what we call the counter movements is shaping the climate narrative. But what we're seeing as well is that the negation of the climate narrative is coupled with the denial of the efficacy, the safety, and the benefit of vaccines. And then you add some gender denial. And overall, these cultural resistance or counter-cultural resistance, which certainly is having an impact on public health, is framed around, a narrative and a messaging of freedom and questioning scientific consensus. So, you just need to walk around social media to see how well organized and impactful this countercultural resistance is in terms of affecting the work of the public health agency. So all these ingredients combined is really shaping to be a perfect policy storm. And some of the challenges that are here just reflect what I've shown you. And this is why the climate change or the response to the climate crisis has become a systemic, if not sectoral, public health challenge. So the public health agency really needs to work much better. Public health agencies really do know much better with the many other actors in the human, the animal, and the environmental and social spheres if we are to be successful to address the challenge of the climate crisis. So I hope that this lightning fast context was useful to shape the talks of the colleagues in the session, and I'm really grateful for the opportunity to be here with you, and apologies again for my voice.
Thank you so much, Enrique. Yeah, such a good context to the whole session and a great introduction for the conversations. Thank you. Okay, I'll now hand over to Sonia. Thanks.
So here we go again. One more try. I apologize for that. Okay, can everybody see my screen clear? Yeah?
Yeah, thanks.
Excellent. Yes, so it's a delight to be here. Thank you so much for inviting me to join you. And Enrique, thank you so much for that very comprehensive overview. I'm going to take us perhaps a little more locally and talk to you a little bit about how we should adapt health policy with a real focus on U.S. health systems in responding to what Enrique so very nicely gave us a global understanding of. So just to do a little bit of ground setting, because I know many of us on this call today may be from the US, but also from around the world, and our health systems are very different. So in the US, health systems are not just one. We have public health systems that sit distinct from clinical care systems. They're both health systems, but they're really separate in the way that they're funded, their mission, their resources, and their expectations. So when individuals are experiencing either the effects of the public health system or the care delivery system, they're not necessarily in sync. They're not necessarily working together. Public health systems include the very traditional public health departments, government sponsored, but of course this very broad patchwork of other organizations across the United States that help to promote public health from many different positions, nonprofit and community as well. Clinical care systems tend to be a little more organized, but oftentimes are very focused on their members in terms of their mission and responsibilities. And so while the systems are both integral and a part of advancing health in the community, neither one independent of the other really can move the system forward. And since they're not all in the same tent, it's important to really think of them distinctly. And when we think about policies, you really need to think about working in each one separately. Also, just sort of ground setting for policy. So oftentimes when we think of policy, we think of legislation, regulation, these sort of big, clear, required, mandated changes. But of course, there are many other kinds of policies, court decisions, guidelines, or recommendations that may not be mandatory, but actually shift the way in which a system works, as well as directives. So that can include an executive direction given, for example, by a mayor as an executive order or another government leader or institution. In the end, the one thing that's really inclusive about all of these is that this is an opportunity to really shift the way that systems work by passing policy. And when one does that, the hope and the expectation is that you start to create a sense of fairness across communities that are interacting with that system, because the system then is reacting to everybody as they come, rather than selectively making decisions. So policies are very effective, and we use them commonly in public health, and there are many different policies beyond bills and regulations. So as we talk about our climate and the effects that it's having on our health, this is what we see most commonly, right? These are the acute extreme events that come to us live in our living room, or if we're unfortunate enough to be in the place that is affected, directly into our living room. But the experience can vary. It's typically time limited. And as viewers from the outside, the thought is that the threat comes and the threat goes. These are intermittent threats, which means that there's an opportunity to breathe in between and to assume that there aren't any other effects of our climates beyond these very large events. And that can be really detrimental to the way we go about our work. That doesn't mean that it's not essential to absolutely prepare and respond using our care delivery systems and our public health systems with all of their force to these extreme events to protect life and goods and livelihood as well. But that's not the end of it. And when we limit our conversation to these extreme events, we miss opportunities to advance and communicate with others about our needs. So this is what most experience, right? Even if we don't call it or name it as a part of climate change, so to speak, the weather in where we are is part of a changing climate. So this was in New York City on June 7th. For a brief time period, New York City had the worst air in the world, and this was due to wildfires that were raging in Canada. We knew that the smoke was moving across into the continent along the eastern seaboard, and yet that day I was in clinic seeing patients, and they were coming in to walk-in clinic. They were missing their regular primary care visits. They were telling me about chest pain, chest pressure, their lungs hurt, their eyes hurt. Interestingly, though, many of them didn't even associate it with the weather outside. And so the two things that this drives home is that this is a common experience, but even when it's common, we don't label it and we don't talk about it that way, not in a way that actually makes people really understand that we're all living with it. And what's common is something that can bring somebody into the conversation in the long term. So this is a moment to just pause. As was mentioned in my introduction, I am at Johns Hopkins. I'm a researcher, and most of my work at this time is really focused on health systems. But the reason that I arrived in this place is because I have spent many years focusing on government public health, working in government in New York City as a deputy commissioner, in California as the director of the health department, and in the CDC in global public health. And what is common in both the care delivery system that I just told you about as a provider in an outpatient clinic dealing with patients, and what's also common to the public health system is that neither one of them, in my opinion, and in my observation and my experience, were really harnessing the tools that they had to be able to react and respond to the ongoing persistent impacts of climate on health. The weather patterns like heat and poor air quality on the health of either the patients that we serve or the communities that we're responsible for in the care delivery system or in the public health system. And for that reason, my focus has been really thinking about how can we make these systems more responsive to protecting health. To illustrate this further, on the top part of this graph, you see the events. So as we think about hazards, heat waves, floods, surges, hurricanes, wildfires, all moments in time. And yet across the spectrum, these other ongoing changes like increasing temperature, sea level rise, loss of biodiversity, changes in precipitation, changes in air quality, those continue, but they often continue in a very invisible way. So this is one of the first sort of points about adapting health policy, is that there's a lot of space, even in a country that may feel quite divided. There is a lot of room for common ground if we explore and talk about it in this way. So this is from the New York Times. This is showing the 30-year temperature compared with the 20th century average over time. On the left-hand side, it's 1901 to 1930, and the right-hand side, the temperatures, the increases in temperature from 1991 to 2020. And one of the things that this clearly illustrates is that these are not discrete, separated locations in the United States that are experiencing this. This is a very common experience that we have at the local level. This is adapted from the WHO, and I find it very helpful to use talking with communities and really thinking about how we change our systems and where we have opportunities for leverage. So at the very top, you see the environmental change presents a health risk, which is the product of vulnerability factors. So this is the individual, whether or not this is their specific underlying health conditions, their age, for example, cardiovascular disease, hypertension, all of those other elements that make them more susceptible. The social conditions around which shape and define the resources they have access to in order to adapt and to protect themselves. That is combined with both the climate hazards. So if we think about heat and poor air quality, and then finally the exposure, which is the degree to which that hazard, the individual or the system actually integrates or interfaces with that hazard. And in sum, the health risk is defined by this interaction between the hazard, the vulnerability factors, and the exposure, ultimately leading to a whole host of health outcomes and impacts on our care delivery systems and all of those non-medical drivers that impact health. And here is this another second point to think about as we're looking and exploring ways to develop policy, and that is that language matters. So when we're speaking with the public and really trying to explore places where we can act together, in climate speak, we talk about mitigation and adaptation. Mitigation being actions that can help prevent climate change overall, and adaptation being actions that can help protect us against the impact, in the case of humans, the impact of these hazards on our health. But that's language that's not common to everyone. It certainly feels like it's in a specific space. And yet, if we're really talking about things that are common, we should think about how we might be able to communicate these issues in ways that are common to people and common to systems that we need to respond. So another way to think about this is to talk about prevention and control when it comes to adaptation, particularly when we're talking about health systems, about public health systems and care delivery systems. Because in the mission, it's very clear that these institutions are responsible for helping to prevent and control the negative health impacts that occur due to a whole host of medical and non-medical drivers. So to just sort of drive this home a little further, in New York City, for example, there are approximately 500 deaths due to heat each year. The vast majority of those 500, only 6 or 7 are due to something like heat stress. The very direct impacts, the vast majority, almost 500 deaths, are simply due to exacerbation of underlying conditions. Underlying conditions that have already been diagnosed can be controlled. These are opportunities, if we use our systems, to prevent those exacerbations and to prevent those deaths. The other key point here is that of those 500 deaths, only 20% are occurring during the temperatures of 80 to 92 degrees Fahrenheit. So that in the United States, that falls right below the threshold that would have triggered an emergency warning. That means that these individuals, the vast majority of individuals who are dying from exacerbation of underlying conditions, it's actually occurring at temperatures below which we would have been activated by our public health systems. This is because we spend fewer days in those very, very extreme heat temperatures. And while the risk absolutely is greater when the temperature is higher, because we spend much more time in this sort of higher temperature but not extreme temperature, that's the temperature where people get into trouble. And so when we think about how do we motivate systems response, we need to think about which systems can actually reach the populations that we're trying to reach in order to protect and prevent adverse effects. So this is why primary care is essential. It's because, within the care delivery system, because non-optimal temperatures happen well below the extreme temperature. So when we look at this graph here, which is a J-curved graph that shows the minimum mortality threshold, which is where death is the lowest, the risk of lowest from a temperature perspective, you'll see that it increases radically very much on the right-hand side, which is increasing temperature, and on the left-hand side, which is decreasing temperature. but that the risk starts to increase almost immediately from the non-optimal temperature. And when we look at the from a public health, care delivery system, cost is also of concern for the systems to be able to operate efficiently. And so this is what we see is almost the exact same curve, looking at the change in 3-day emergency department spending per 100,000 in fee-for-service Medicare enrollees. So Medicare is our government program for individuals greater than 65 years of age. And what we see here is, again, you start to see this intense spike when the temperatures hit starting at around 85 degrees to 90 degrees, increasing. And this is looking at ED spending, emergency room spending, and they're comparing also when that emergency room visit turns into a hospitalization, which is where most of the costs come from. So this is preventable, and it's costing the care delivery system. And when we look at the individual, we also know that there are a number of attributes of the individual that a primary care provider in the care delivery system would also be aware of. So individuals who have underlying cardiovascular disease, diabetes, lung disease, a whole host of underlying conditions, kidney disease, all of these individuals are greater risk. Also those who are greater than 65 years of age, and also at the younger extreme of age as well. They're increased risk. And we know who those patients are in our care delivery systems already because they are our patients. As well, the way that we treat our patients can exacerbate problems. So this is a list that comes from the Centers for Disease Control of medications that can impair an individual's ability to thermoregulate, to maintain a healthy temperature when they're exposed to very high temperatures. And so you'll see here that the medications fall under many very commonly used medications, many common conditions, cardiovascular disease, psychiatric and neurological conditions, as well as diabetes and others. And many of these conditions, for example, for hypertension, all first-line drugs that we use for the treatment of hypertension fall into these temperature sensitizing medication groups. So it's not only knowing the patients, but also understanding that what we do to manage and improve their health can also make them more susceptible to heat. So what can care delivery systems do to prevent exposure and control the sensitivity to exposure? We can do this at the systems level through a few different ways. One is through thinking about our patients, identifying our patients at the provider level, understanding what's needed at the systems levels, using the tools that are so common that we have to apply it to these situations. So just for example, electronic health records. We can use electronic health records to pull panels of patients. We can use electronic health records then to identify people who are at risk, and then to put in care flow modules that can alert providers to different kinds of actions that they should take. So for example, if we know that the poor air quality is coming in a few days, we could pull all of our patients that have asthma, check to see that all their medications were refilled. If they weren't refilled, we could automatically refill them and then send them a message saying the weather is going to be very poor. We're worried about your asthma. Your medication is refilled. It's waiting for you. Pick it up. Oh, and we can switch your in-person visit to a telehealth visit. So there's many things we can think about if we pay attention to the precision opportunity we have for identifying patients at risk and to respond. These are policies that we can put in place, policies within our health systems, policies that can protect and prevent patients from getting into trouble due to changes in the environment, changes that happened now, not in the future, but temperatures and poor air quality that they're experiencing now. These are all things that are within our control. Public health, of course, is also essential, right? Because place matters, and not all patients are in every single care delivery system in the United States. So this is also very important because we have differences in our communities that vary and would only be detectable through local analysis and response. These are maps of red-line neighborhoods in San Francisco looking at air quality. On the left-hand side, you see the neighborhoods that have been redlined. Redlining was a race-based policy that was put in place in the 1930s and onwards, now illegal, but basically limited investments in communities based upon the characteristics identified. And therefore, those neighborhoods would be redlined based upon those characteristics. So these redline neighborhoods still to this day, even though the policies no longer exist to prevent investment based upon those characteristics, that disinvestment that occurred is a legacy that continues. And you'll see here that those red line neighborhoods have increased rates of nitrogen dioxide pollution. And then the percent of people of color in those neighborhoods also are in those red line neighborhoods, in those neighborhoods that have higher levels of nitrogen dioxide, are also higher. This is done by the New York Times reporting. And so these are the kinds of things that public health departments, this is within their remit to respond to. And so public health departments have a number of different 10 essential services that have been described in the United States and tools to help them advance them. And so I just want to talk about a couple of key tools that can be used, as I did in the care delivery system. And one of them is surveillance. So we know that surveillance, the information that we get in understanding the health status of populations, can be used to help us identify concerns, trends, and to develop interventions that can help prevent and protect those in our community. This comes from New York City, and this is from their dashboard or their report on heat and heat-related illnesses. So across the bottom, you'll see you'll see a chart of emergency room visits due to heat-related illnesses. And on the top, you'll see temperature as it's fluctuating. And this allows health departments to understand the impact that heat is having and also to be able to design policies and interventions that then can protect individuals. So heat is a very well-developed surveillance metric in the United States, but not so much in other areas. So this is really another important area for growth and development in response. And in the end, when we have the technical knowledge, when we have that data around surveillance, we can develop the capacity to act. And that's when we have the will for policy. And it's from here that we've seen very interesting policies also evolve at the state and local level, from Arizona introducing a heat officer specifically focusing on heat within the health department that then works across all of the agencies to help develop and advance policies. In Minnesota, focusing on mental health and its interface and concerns about the impact that climate may be having on that. The state health department has developed their modules to train providers and to teach patients and individuals how to be more responsive and understand the impact that climate can have on well-being and health. And in Oregon, the health department there has used their understanding of inside temperatures, outside temperatures, the ambient experience of their patients and the community at large to harness and use resources to be able to identify patients at increased risk and purchase air conditioners, help them address energy insecurity so that they can run the air conditioners to make sure that those that are at highest risk can protect themselves when the temperature gets very hot. So I'm just going to close there just as thinking again, really just emphasizing that there are still lots of opportunities in health policy and in particular using tools in novel ways that already exist within our public health system and our care delivery system. And some of the really key aspects is making sure that we lift up the common experience as we talk about our climate and the way it affects our health. And that includes the ongoing persistent impacts of weather. That we highlight what's happening now. It's important to understand what's happening in the future, but what really moves people to action is what's happening now. And as I shared with you what New York City was doing in terms of reporting, when we provide numbers, we help ourselves really understand the impact and what may be preventable or not. So when we talk about heat or poor air quality in our communities, we can do that to really bring people to a common understanding. Really think about responding to local needs. So think about local hazards. Not every community has the same hazard. Not every community needs to prepare for the same hazard. And also to consider what the local community infrastructure is. Work with systems that are already responding to the impacts. And that's why health departments and care delivery systems are so important. Their remit is already prevention and control. And so therefore, a response to this is definitely within their responsibilities and opportunities. Use language that's familiar. I found it very effective to talk about prevention and control because that's what those departments, that's what doctors use when they talk with their patients. And it's a response that works very effectively. And then finally, identifying gaps in systems response and build that into those systems. So as we build a system, we also can build the case, and that case can be described by improving health, reducing costs, and increasing efficiencies in systems. And through that real framing, I think we're really able to work at many levels of policy, different kinds of policy, but policies that can impact the health of people today and ongoing. And so this is a big tent. You know, there's many opportunities to bring others into the fold. It's an opportunity to find common understandings of common needs to develop common solutions in our communities. So with that, I'd just like to thank you for your time and pass it along. Thank you so much, and happy to answer any questions at the end.
Thank you so much, Sonia. Some really great data there, and great to see some actionable, practical points and proposals. So thank you. So last but not least, I'd like to welcome Laila to the virtual stage. Go ahead, Laila. Thank you.
Okay, thank you very much. Thank you for the Public Policy Center for inviting me to talk today. When I was, well, I don't have a PowerPoint, I'll just speak. When I was asked to talk about the subject, it was very hard for me to choose a focus because I think health is a major subject, and climate change as well. And they're both subjects that are subject to political ideologies, to political practices. So one of the things that came to mind in order to try to explain these relationships in the way that I find meaningful is by trying to understand what health is, or how health is used in a world in which we're living massive extraction and sacrificial violence. So right now we have a world that's at a state of huge environmental crisis, also of social crisis, of fascism, genocide, massive neoliberal politics, which are leaving the market, trying to regulate everything, but as we see, it doesn't work. And at the same time, contentious politics has been reduced, and it's been neutralized by both inequality and also technocratic approaches to politics. In this context, I want to ask, what does health mean? What does health mean in a fascist world? And what does health mean that relates to both the discourses, to public policy, to a whole array of ideas that are linked to health? I wanted to put two examples to start this presentation, this elaboration of ideas. The first example is very recent. Well, actually, both examples that I'm going to start with are very recent. The first one is that this week, the UN voted against torture. Well, it was a resolution to prohibit torture. And 3 countries voted against this resolution. Which 3 countries were they? There were Argentina, US, and Israel. And this example, it might seem something that doesn't have to do with health or that's geopolitical, but at the end, for me, it shows how our world, our institutions, nation states, they're framing their politics around structures of what can be called disposability. Which lives, which bodies, what health is disposable? Countries, entire nations that have a huge political power right now are voting against prohibiting torture. So that already shows how we have this whole political atmosphere that is trying to condition what health means and what which bodies are disposable. And so that's like the first example I wanted to put to set this panorama of health in a fascist world. And the second one that I wanted also to talk about is the avian influenza. And for me now, the avian influenza, now we have a crisis in the world with avian influenza again. It shows something that from environmental activism and from political ecology has been said for decades, and it's that the basis of our systems on which we rely on which our health rely on, are being destroyed. Mike Davis, he wrote a book in 2022, I think, called The Monster Enters, in which he talked about pandemics and the past avian influenza as a result of the production models that we're creating. So we're creating these conditions of disaster through massive extractivism, through cutting down forests, through polluting water, and the effects of that are health effects. So this example shows a little bit this context of eco-social crisis. It shows our relationship with nature, how it's broken, how we're creating the basic conditions for destructing the possibilities of health itself. And within that, if we are living and creating a model which destroys the possibilities of health and the possibilities of life, how do we talk about health? And that is my main concern. So for me, health is not an outcome. It's not a biological outcome. It's not the absence of disease, which is the traditional health definition of the World Health Organization, but health is a political relation. It's a political relation within another political relation, that is climate change, how climate change is viewed, which effects are prioritized, and how at the end the political decisions that are made regarding climate change. And now we come out of a week in which COP30 has shown how climate change is precisely very political, and how the fossil fuel lobbies are exacerbating climate change intentionally and openly. So this is the premise that I'm starting with, that health is in a fascist or an increasingly fascist world, because not all structures obviously are fascist, but we have a critical situation, and there's genocides, there is mass conflict. We have a really critical situation in which, for me, health is all of that. Health are the bodies that are being killed, the people that are being killed and expended. So it's important to understand this non-neutrality of health, and how health politics, or even health management, which it's also an idea, has a tendency to create a dispensability. And here I want to talk about another concept, which is end-time fascism. That is an idea that Naomi Klein and Astra Taylor created or came up with, which talks about how in this world, where every time the living conditions are becoming worse due to this destruction that we're imposing through economic product and production models, living conditions will be every time harder, but there will be a small part of the population which will try to benefit from them, which will try to create privileges out of this and isolate. And this idea of end-time fascism, it made me think about health itself. And there I came to a link which is quite interesting, that in Spanish, health comes from salud. Salud has an etymological origin that is related to salvation. It also has another origin related to wholeness, but for the purpose of this metaphor, salvation is the one I want to focus on. This idea of salvation, it's very linked to anti-fascism. So if we see health from this mentality that elite, privileged, political, high position leaders, corporate sector have as a political position, health becomes an idea of who is saved and who isn't saved in this world. And it becomes basically, health institutions can become boundary policing institutions. For example, in a world that where water is every time more polluted or scarce, who gets access to fresh water, who gets access to clean oxygen, who gets treatment first, who gets asylum. All of those are questions which are deeply political, and a true health policy has to be related to all of this as a whole, not just to a problem-solving approach. Within this perspective, I think ecofeminism is an outlook, a political outlook, and also a practice. It's a whole way of changing our perspective on the world that becomes very important. And it can help give some keys of first having like the keys to establish how all of these systems are interacting to create dispensability and sacrificial violence, and on the other side also to turn it around, how we should rearrange our world and our systems in order to have real health and to go to these problems from the root. And well, what do I mean by this? in the first place, ecofeminisms, what they center on are relationships, and specifically they denounce the relationships that are broken, the relationships between society and nature, how that relationship is broken right now, the relationship between us with the other species, and then also relationships with our own bodies and with others. These relationships are sometimes framed as ecodependency, interdependency, and intradependency. So when those relationships are broken, we have a whole set of crises, and also and we have networks of resilience that are broken, because this idea of fending for ourselves, this neoliberal idea of individualism, of fending for ourselves, of not needing communitary approaches, that collapses, because we are actually interdependent, and eco-dependent. We need networks to survive. And the ecofeminist perspective allows to see this, and also it allows to see when and what injustices are occurring in relationship to this. For example, it puts the spot on unpaid but also paid reproductive jobs, which are precarious, and which are actually the basis of sustaining life, which are the basis of sustaining others, which at the end is the basis of health, but they have the worst working conditions. And also ecofeminism puts a gendered light on this. An example that I want to point out is, for instance, jobs in Spain that are in agricultural sectors, and specifically in the agro industry, which are many times based on racialized workers that many times don't have a regulatory status that is legal. Therefore, they don't have an agency compared to the rest of the population, and they are set to work in very precarious jobs under very harsh conditions. And here's linking back to climate change. Here's when climate change goes in and creates a very unfair effect and a very violent effect. This summer, there was a worker which died in Lleida, and it's a province in Catalonia. Died due to being working in the agricultural industry under a heat of over 40 degrees Celsius. And different collectives that are anti-racist collectives say that he didn't die. He was murdered by all of these systemic arrangements that at the end create a system of racialized workers that work in the reproductive sector, and they maintain what makes all of us healthy, but it basically is a form of sacrificial violence. And for me, that is key. Understanding health as this unjust, violent system is the essence of what I think we should be thinking about in this world that is at a bridge of catastrophe in many aspects. And it also promotes a whole rearranging of life. Nancy Fraser, she talks about cannibal capitalism, which is how our capitalistic system, it basically eats the basis of life, which is what I've been mentioning throughout the talk. And within this, ecofeminisms, they say that this should be turned completely around. We should be looking at everything from health systems to our agricultural systems, to education, to how we research, to how we interact with others from another place that places reproduction of life at the bottom, that criticizes, that critically puts a focus on neoliberal ways of thinking, of acting, and of doing, and therefore can put another focus on sustaining life intentionally and out of marketized of market systems. And this is what I think has to be in the whole center of a true health policy, which links, again, going back to the health in a fascist world. It would imply also real health policy is political positioning towards stopping the genocide in Gaza. It's real positioning and action towards stopping forms of production of consumption that are extractivist and directly harm the health of communities that live in other parts of the world. That, for me, is the basis of a true health policy that is that goes to the roots, and that isn't a reformist approach. And well, a little bit closing on these ideas. All of this also involves a very strong collective liberation or collective assembly, because better health, in order to acquire this broader, this political, this agency, which we think of health as something that is deeply political, that is deeply ingrained, that is what makes us function in life, it also must be performed bottom up, because from top down positions, the solutions, as we've been seeing in the past decades with many health conferences, with many sustainable development conferences, etc., they haven't radically placed health in a place that is deeply political. And I think all of that can turn around from a bottom-up approach. And finally, looking at other levels, and as Sonia and Enrique commented, I also think primary healthcare has a huge role. I think that health practitioners, if they are understood, if they actively ingrain this message of health as a fundamental part of politics, then their day-to-day professional would be stronger. And the other way around, if society understands politics as a health issue, then also politics would be emphasized stronger, because we understand that health, if we understand that health is the basis of life, then we would ask for politics in a different way. And well, that's what I wanted to explain. It's my idea that I've been thinking about is that health in this world where there's sacrificial violence, where there are politics of disposability, in which contentious politics is very low, it requires a radical reemergence of health as a political concept, of health as something that is everywhere in all sectors of life, in all jobs, and that we must position it as there as a central and conflicting point in order to rearrange all systems towards something that actually results in a healthier and a more sustainable, in a better world. And personally, I think that health should pass us from an idea of health as crisis, as a momentary risk conceptualization of health, to health as political violence, an idea of how health sustains all of these political systems and these disposability mechanisms, to finally a agency of health as resistance beyond extraction.
Thank you so much, Laila. Thanks for closing the presentations with that really interesting and critical perspective on the issue. So yeah, thank you so much to all three speakers. That was a real great range of views and experiences and perspectives in that panel. So yeah, thanks to all three of you. So so far I've only got one question, so please, to all the participants, please go ahead and share your questions. If you prefer to say it out loud, please just send us a message in the chat, and I can allow you to speak. So I'll ask the first one that I've got, saying, thank you very much for your presentations. I found them truly insightful and helpful. One concern I had is that until Laila's presentation, the role of the broader socio-political system in shaping both the climate crisis and the capacity of public health systems to respond to it did not receive much attention. My question is, from a public health perspective, what strategies do you see as most effective for identifying and communicating the systemic causes of the climate crisis in ways that can raise public awareness and eventually support popular organizing, political pressure, and meaningful policy action? So that's not directed to anyone specifically, so anyone can go ahead.
Did you want me to, as it is like from a broader public health, I suppose there was a little bit of that tension between the public health and the politics, our political system, in terms of like the different timings and the different forces that we have to combine, isn't it? But I suppose we have got two challenges. Thinking about the communication to the public and drawing from what we know in terms of other crises, such as the drug-resistant infections crisis, the public cannot really see easily how the temperature is increasing and the impact it can have. It feels hotter, we've got longer hotter days, but as long as society still sees, for example, that the increase in temperature in some countries is something that newspapers present as something nice, it's quite difficult to associate this increase in temperature to something bad. And the fact that it's difficult to see and feel the impact, the negative impact of the climate crisis on the average citizen or for the average person, we need to come up with better ways of showing to the average citizen why that is a bad thing. And equally, we cannot forget that already citizens are telling us that there is a negative impact on the psychological health of the climate crisis, isn't it? And already we have got a lot of evidence about eco-anxiety, solastalgia, and the difference of the eco harms. And these concerns and these pathologies are legitimate. So we cannot forget that considering this impact can have a harm on the individual. And, I feel uncomfortable sometimes when we put a lot of the onus on citizens. Thinking about the policymakers and politicians, I think that in public health, we have been a little bit naive, assuming that evidence meant understanding and action. And the whole narrative about, well, all you have to do is a policy brief and a policy brief will get you there. I think it has been a little bit naive because we forget that decision-making at the political level has got a component of ideology, which is absent from our scientific work typically. I mean, scientists, we also have got an ideology, but our work has strived to be as aseptic as possible. Political decision-making and politicking don't have to abide by that asepsis. So I think that if we can understand that ideology is an important factor, maybe our scientific messaging will be, on target a bit more. But
my thoughts on this are that public policy has to focus on building an agenda that's really separate from market-based interests. At the end, market-based interests, you can't measure lives in economic value. And the states, public sectors have a role in focusing on lives, not on the economic value, because for that, businesses are doing business with what they do. So for me, there has to be a very strong, clear division between what it is of protecting of public institutions, public financing, for example, healthcare for everyone, and not falling into more private-public partnerships or all of this consensus-based mechanisms, which at the end get closer to market-based mechanisms. And I think that's a type of stop or a type of a mechanism to at least allow more space for citizens to then be able to intervene in public policies, because I think it's citizens who have to be the ones that have a say in this.
I don't know if Sonia, there's anything you'd like to add, or?
I mean, I would just acknowledge and recognize just the importance of public health systems and care delivery systems and really empowering individuals with the information that they need to be able to understand their environment and to be able to take action. And those, I think, are really, that's about creating healthy environments for everyone everywhere, and why systems change is so important. And systems change that really can help allow people to access services that they need when they need them, and to live in communities that keep them healthy when it's not just about preventing or controlling an impact immediately, but something that's long-term and ongoing. So really understanding what kinds of aspects in our neighborhoods keep us healthy, and making sure that we design systems that can help support that.
Thank you. I've got a question in the Q&A. So this is from Edward Z or C. I'm not sure how that's pronounced, sorry. Can you discuss the tensions between interventions within healthcare and medical institutions and policies that aim to protect and promote health, broadly defined? And that's for anyone.
So I would love, I don't know if there can be a little more clarity on what the tensions, an example of a tension might be, unless some of my colleagues on the here are clear on what an example is that he's interested or she's interested in.
I'm thinking, I'm not sure if the question has this approach, but I'm thinking that perhaps it's looking at tensions between biomedical systems and then other broader social, eco-social determinants of health, or broader politics. I was trying to say in my discourse of health basically being part of all aspects of life. I'll go ahead while thinking that this is the kind of the tension or the dichotomy that the question was referring to. I think that I think that biomedical forms of medicine, or specific medicine that's aimed to direct itself to, well, to already like a body level individual disease, we traditionally understand as health, which goes back to the World Health Organization definition of absence of disease, the original definition. And I think that definition per se doesn't have to be discarded. It's necessary to solve, to give solutions, to have systems that are strong and that allow us to recover when we're sick. So it's not a question of it's either or. But what I was mainly trying to emphasize is that while that is the main focus of health in general and of public health, it's how biomedical institutions or health framed like in this separate bubble or sphere. The other part, the politicizing health from another point of view, from a very radical, from a very political perspective, that usually isn't applied so much. And so that has to be, in my opinion, strongly emphasized, because that is the core to not leave health in a problem-solving mechanism forever. If we address health truly, and if we want to make health from the biomedical, from the clinical perspective better, what will really help it be better will be addressing the root causes, will be addressing extractivism, militarism, racism, patriarchy, all of that will be the fundamental target to get good health. So I don't think they're either or. I don't think it's this dichotomic relationship, but I don't think the biomedical and then all the industrial part that's associated to that should be dominating. Rather the opposite. How are the conditions for life to be reproduced? Can those be promoted?
Thank you. Does anyone want to add anything to that, or offer? Okay, no, if not, we'll move on to the next question because they're starting to come in now. So, okay. So from Carolina, how can primary care become the detonator of the necessary radical change? For example, how can we even begin to tell our patients that redlining leans on their health almost 100 years later, except by questioning the whole economic system that Laila so correctly points at as the root cause? These maps are not known by the people.
I can go ahead to try, but I'm not sure, like the question, I think it was trying to ask how this idea of a whole structural cause of unhealthiness, how can that be more or less spread out throughout the population? Is that a little bit?
I understand. I mean, if Carolina wants, I'll allow Carolina to talk, but I understand they're asking about primary care. So maybe how can primary care and primary care systems and workers be utilized to create this kind of deeper change? I think so. But Carolina, if you want to talk, please go ahead.
Yes. Yes, thanks for taking my question. Yes, I have been working in primary care, trying precisely to integrate the social determinants of health as, or the social drivers of health into the radar of our primary care clinicians so that they actually can understand these larger factors as they lean on our population, our most vulnerable population. And I love Laila's vulnerability sort of distribution between, ecological interspecies and intraspecies. That's exactly what we are proposing. But it is that the healthcare system is so aligned with the economic system that, you have our electronic health record, and what they mostly want to focus on is take away the context of the story of the patient, see them in 10, 15 minutes, and then code for revenue producing to our, capitalist, profit-driven healthcare system. How are we going to turn that big ship around so that the information that matters to whether our patient is facing inhuman conditions out there is leaning on their biological well-being is not even receptive, is not even received by our own clinicians, given their timeframes, their metrics, and their demands on their productivity in terms of money. So we take this public health helicopter views of redlining and say, well, you have all this population being affected by the legacy of this historical and cultural, discrimination for decades, almost a century. So doctors, be aware of this, but we're not telling this to our patients, that their health is being affected by this legacy. How do we begin to activate the critical, understanding of our most vulnerable people so that they can actually take this individualistic, blame the victim type of message that they get from biomedicine, that it is their problem and their genes which make them sick. And unless we acknowledge that we have a sick society, then anything that you don't adapt to this society is your problem, is not the society. So here we go to the structural questioning or upstream that needs to be created that doesn't exist. And we need to create it. And I think primary care, pointed by several of you, is the place where this information can flow into our institution before the population loses the trust of the public, because we are in that moment. Our patients tell us, I don't trust them. All they want is my money. They don't care about me. So how much are we going to keep up this healthcare system driven by profit and just be blind to this conflict of interest? Thank you.
Thank you so much. I don't know if maybe that's more relevant to Sonia as I think she's the only one. Oh, well, Enrique, just thinking in terms of the for-profit healthcare system, that's maybe more relevant to the US, but Enrique had his hand up, so please go ahead.
But I think that I think that Sonia is best suited at had a reflection, but I, you know, if Sonia doesn't mind because of the context, but yeah, I can make the reflection a bit later.
Oh, I mean, I can just add a comment here. I think to make it's very difficult to make generalizations about primary care delivery systems around the world. They're all very different, and they're different. I think Carolina, you point out that there's different kinds of care delivery systems, some for-profit, some non-for-profit, some government-run, very, very different and function differently because, at least in the United States, we don't have one healthcare system. So in other places, this might be a very straightforward question to answer. For me, this is very difficult to answer because every system manages these issues in different ways. Many practices that are working in designated areas where communities have fewer resources and the environments are have less health promoting characteristics, whether it's because of redlining, disinvestment, et cetera. Many of those clinics are very, very aware of the issues when they're dealing with individual patients and make sure that they are directing them to resources they can use. So my personal experience has not been one where we're blaming the individual for their illness. Rather, we're trying to help the individual identify tools in their community and that we may provide them, whether it's medication or resources to be able to become healthy, to be able to change their environment. But not any one system is going to change every other system, right? So every system in its own way is going to be able to provide different resources to help communities. And some may be more focused on that effort, some may be less focused on that effort. I think was pointed out earlier, we have I don't think anybody in the United States would say that our health system works particularly good. It doesn't. It gets to us too late, provides resources when we're already sick, and doesn't necessarily do a good job at keeping people healthy. But I do think this is the complement of public health and primary care when they're working well together, because they have very different responsibilities, very different authorities, very different access. And when they're designed and thoughtfully introduced or used or worked through communities, they can be the very tools that help to change environments so that people can overcome many of these obstacles that they're already facing. There are many examples of using community health workers to reach communities earlier, to identify needs they may have for food. I gave you the instance of addressing energy insecurity when you give somebody an air conditioner, for example. These are very basic, specific things, but they're also things that can save lives. And they're very specific to what a care delivery system can do that's unique to an individual. Care delivery systems by design, though, in the United States, care for individuals. They may care for cohorts of patients too, so sort of panels and groups of patients, but doctors, physicians, care delivery teams work one-on-one with patients. So that's really the lens through which I've seen many of the most effective change come, is through working one-on-one and providing resources to be able to overcome limitations.
Thank you. I don't know if anyone wants to add anything briefly, because we're getting close to the end and there's a couple of new questions, so it'd be great to be able to cover all of them.
I suppose this.
Sorry.
Go on, Laila. No.
I've talked a lot.
Just briefly, I suppose it may sound controversial, but when I see patients, I feel that sacred space between the patient and the clinician may not be the best place to address the planetary forces that Laila has mentioned and that we've seen in the literature. And I feel a little bit uncomfortable when that sacred space of, between the individual and the other individual, is that the right place in that long chain of determinants and effects to try to address? And all I can think of is, probably it's not possible for us to advise that people vote in a way that ensures that those political forces are aligned with the welfare of not just humans, but the other beings. But I just think it's such an uncomfortable space to think about anything else as not the person in front of us, thinking about patients. But it's just a reflection.
Very briefly, I was thinking of environmental justice movements when you were asking the question, Carolina, and how environmental justice movements, they originated, they aligned due to the health consequences of environmental impacts, and such as waste plants, nuclear toxicity, well, a whole array of causes. And so those movements, I think they can also help show how collective action emerges. I'm not sure the role of primary healthcare, but I'm sure they were also important, because at the end, when someone is sick, they go to a primary healthcare, and in primary healthcare, all of those causes, all of those different individual problems, they join together in one space, and it's a space where the professionals see all of that, and that can be also very helpful to align with these bigger causes, with environmental justice problems, with something farther on, which also makes me think of the ecofeminist perspective. If our daily lives every time they make it more difficult to be in connection with our own bodies, there's like a disenfranchisement of our bodies and of our times, a primary healthcare center, it makes us refocus with that, with what's happening to us. So there's a point of connection, maybe indirect, in a one-to-one basis, but it's more than the individual. And I think there's interesting connection points between all of that.
Thank you so much. So there's two questions. The first one, I feel like it's been kind of touched on, and it's maybe a bit more philosophical, rhetorical. So maybe I'll just read it out, but no one needs to reply to it, and then we can just answer the final one before finishing. So the first one was from Christos, and it says, "Is politicization of science really a problem? I mean, is it not true that to accept there is a human-made climate crisis, inter alia involves accepting the critical role of deeply political forces, such as, for example, capitalism and colonialism, and the discriminative, e.g., along racial and class lines, effects on people's health, isn't discussing how to put a brake to such discriminatory systems a key element for crafting effective health policies in a warming planet?" I feel like this has been kind of explored and reflected on, so I'll just leave it there. And finally, from Farhan, thank you to all of you for your presentations. This question is especially addressed to Enrique and Sonia. You've presented several important avenues for action, but how do we prioritize the most urgent systems level changes needed to protect population health in the face of the climate crisis? And how can academic institutions like yours best contribute to driving those changes?
Well, I know we're short on time. I'll just give a quick response to make sure, Enrique, I'm sure you have many thoughts on this. But I think one of the unique ways that academic institutions can help support systems level change, particularly in public health departments, but also in care delivery systems, is our ability to be able to introduce methods that allow us to understand the impacts of policies and programs, to be able to measure and assess those, and to be able to help support communicating the findings so that care delivery systems and public health systems can invest their interventions in places that have the most public health impact. Because resources are so few, many times elements like evaluation is the last thing to get budgeted in any kind of program, intervention, or policy. And so academic institutions are ideal sort of collaborators and partners in doing those evaluations. Implementation science is an area of science that helps us understand the strategies that help us disseminate effective models in ways that can then be scaled as well. So there's some of that technical assistance that can be provided. Public health systems and care delivery systems really should be listening to their communities, understanding the communities, defining the needs, designing programs, and academic centers can help move some of that technical work forward.
I agree with Sonia about the implementation aspect, and I'm actually thinking how our academic institutions, I think that we've been really good with the knowledge mobilization, knowledge translation aspect, but we haven't been that good in terms of science diplomacy and understanding how the policymaking science interface works. I think that we've been a little bit satisfied with that aspect of mobilization translation, but not the next level, which is engaging fully with the policy making and political making process. So we've got surprisingly very little evidence about how the policymakers or the political policymaker acts and operates. So we really need to grow that space, and I'm really looking forward to have more science diplomacy in planetary health and AMR evidence, really.
Great, thank you so much to all of you. We're going to close there because it's 7:02, well, in Spain at least. Thank you so much. It's been really great to have all three of you today. And what I really loved about today is the range of different perspectives and approaches and ideas from all of you. That's exactly what Policy Dialogues is about having meaningful dialogue between people from different backgrounds and with different specialities and different foci. So yeah, I really thank you for this really meaningful and important discussion and conversation. Hopefully we'll continue the conversation in the future. And thanks to everyone that's attended. It's been a really great session. Thanks for all the questions. And yeah, this is the last Policy Dialogues of the year. So just want to celebrate that. It's been a great year. And yeah, good evening or good morning to all of you. Thanks a lot.